Hi everyone. We're going to talk about brachytherapy today, specifically brachytherapy as it relates to radiation safety. Brachytherapy is a very large subject. I only know a small subsection of it, again, as I have experience with it in just providing safety procedures to the physicists that regularly perform these procedures, just through accidents that have happened at our hospital and accidents that you hear about. But just a quick explanation of what brachytherapy is. It's essentially putting sources in very close contact to where you want to treat. So you can do this through placing specialty molds that adhere to the skin, placing the sources directly on the skin themselves. You can just directly insert them into tissues, whether through catheters and the like, into body cavities that already exist or into actual blood vessels themselves, depending on what you're trying to achieve. In our case, cancer hospital, it's generally just to insert the source into the tumor in order to give maximum dose to that tumor while minimizing dose to other healthy tissues. So this is a breakdown of either permanent or temporary implants. There's different sources, different energies, different activities. So there's many different combinations depending on your ultimate goal of how much dose you want to deliver to that tissue and how quickly you want to deliver it, essentially how many fractions you want to use. So this is to be contrasted with teletherapy. So if you look at the prefixes, brachy, I think it has a Greek origin of close, very close, and tele being very far away. So if you think about a cobalt teletherapy or external beam therapy comes from an external source, whereas the brachytherapy is right in contact. So we'll just go through, again, the thoughts from the safety aspect of it, which really revolve around the dose rate and the type of energy, which essentially is the isotope use. So we have one of the most common brachytherapy procedures we do in the hospital is a prostate seed implant. We've started to see more lung and brain implants, but for the most part, prostate seed implants are our largest form of permanent brachytherapy. So that means that these seeds are implanted into the tissue with no intention of them being removed. So these provide a long period of irradiation. So they are low dose rate and low energy. So that's beneficial from you have that extended period of irradiation that slowly tails off as the isotope decays. And also you have a low energy that keeps most of that energy within the local tissue. So that's good for someone with prostate because there's lots of sensitive structures around the prostate that you don't want to irradiate. And that really dictates the placement of the seeds in order to avoid dose to other areas. It doesn't always go as planned, as we'll see in the accident section of this talk. Another common plaque is an eye plaque. Again, this is also usually an I-125 or palladium-103 source. Both of those sources are very low energy radiations. They stay very localized. For the eye, you want to avoid dose to the brain. For the eye, it's a temporary implant. It's still low energy, low dose rate, but these are put in for a period of time and then removed. So that gives the opportunity to place some degree of shielding around the sources. So these are also these little iodine seeds. They're kept in place by some sort of wax, I believe, and then they're sutured to the part of the eye where the tumor is, and they give a more directional irradiation. And because it's a temporary implant, there's really no significant decay over the 3 or 4 days that they're in there. I-125 has a 60-day half-life, so over those 3 to 4 days, the dose will remain a pretty steady dose rate, contrasted with the prostate seed implants, which will be in there forever until they eventually decay away to nothing. So there is another form that we don't use as much here, and that is the low dose rate but high energy source. I have to be honest, I don't know. I think this is just an antiquated method because using something like cesium, which was common, that's a long half-life. It's a stable isotope, so that's beneficial from a logistics standpoint. But if you're putting those high energy sources into the body, there will inevitably be dose delivered to healthy tissue, and that's something that you want to avoid. Should just take a little aside for a moment and just really focus on the concept of sealed sources. I think we've covered these before, but I just want to reiterate that sealed sources are really, a well-defined subset of radioactive materials. They are sources that you can be confident will not leak. They will not shed contamination. So that is very important, again, from a safety standpoint, because contrast that with loose pharmaceuticals, who almost always have some degree of contamination when they're used. Sealed sources are kind of the opposite in the spectrum, where you can be pretty confident that they will not leak. Now, that's not always the case. There are sealed sources that rupture for a variety of reasons, and that can be a small to very big issue depending on the activity inside that sealed source, the chemical form of that sealed source. We've had iodine seeds that have actually been broken in the OR by a surgeon actually cutting through them, and that leaks a bunch of radioactive iodine inside the patient, which can be a concern because that iodine will then get into circulation and go to that patient's thyroid, and that patient's thyroid can get a large dose from that loose material. So again, another consideration when you're talking about sealed sources, they're not always certainly going to stay sealed, but you can be confident that they, under most general uses, they will. Okay, getting back to this. So we have high dose rate. The previous forms were all low dose rate therapies. One of the newer therapies that actually is used very frequently in our hospital is the HDR source, the high dose rate. So this is generally an iridium 192 source, which is like a mid-range energy. It's not as low as iodine 125, but it's still low enough that the radiation generally stays, the highest doses can be confined to the vicinity of a tumor. These are very short procedures. Because of the high dose rates, they are what we call a remote afterloader, because you would not want to be a physician handling the source yourself. It's generally like a 10 curie source. So that's a very, very high activity. These procedures need to be done in very heavily shielded rooms. Anytime we have a source replacement for these, we have to take a survey, similar to how we would handle, a replacement LINAC. It's a little less extensive of a survey, but you still have to treat it seriously, because the shielding is providing radiation reduction to the areas surrounding the HDR vault that is commonly used. So really, what dictates how these containers are safely stored, how these sources are safely stored, is the photon energy. Most of these sources are photon emitters. There are beta sources. We don't use these as much as the low energy photon emitters. You would use them for trying to achieve the same means of keeping that dose as local to the cancer as you can. So we're mostly dealing with photon emitters. Something like I-125, you can keep that in a very thin lead lined pouch, and that will stop pretty much 100% of the radiation. Versus something like cesium, or back in the day when they were using radium, you needed inches of lead in order to be safely in the presence of some of these sources. So really, the energy dictates the type of shielding that will be present. You generally want, from a logistics standpoint, to keep the sources stored close to where they will be used. Our brachytherapy group has a lab that is in the basement, but it's a pretty close shot to most of the ORs. So that's easy enough for them to take the sources out of storage and bring them to these places, because sometimes you're dealing with many, many, many small sources, and it's easy for them to get lost. So you want to minimize that transportation in order to keep them from getting lost. So as I mentioned, the energy dictates how they're shielded, and the energy has such a huge effect on how much lead you need to shield. Unfortunately, we usually do shielding before this lesson, but I'll do this half value layer. Think of that as kind of like a half-life. Instead of, it's not the amount of time, it's the amount of material you need in place to reduce the radiation present to half that radiation. It works in much the same way as half-life and radioactive decay. You're essentially trying to have the intensity of the radiation a number of times in order to bring it down to a safe level. Something like I-125 had a very, very small amount of lead will cut that radiation by a significant amount. versus something like radium or cobalt, where you need, inches of lead to deal with high activity sources. A big part of brachytherapy, you're dealing with lots and lots of seeds, is inventory. It's one of our most common reports to the city is a brachytherapy seed going missing. We try like heck to find them, but they are tiny. They're essentially little metallic grains of rice. So we have sensitive instruments that are good at locating them, but the problem is a lot of times these patients will already have seeds implanted. So if you go to the OR and look for a seed that dropped into the drapes, the OR drapes, it could be difficult to find a seed amongst sort of a sea of radiation that's already present. Because they're so small, they can easily fall into someone's shoe. We've had that happen before. If we're not called as soon as the source is noticed that it's missing, there's time for people to scatter. If you've ever been in an operating room, there's people coming and going all the time. So it's easy for a source to sort of walk before we're even aware of it, which makes it a lot more difficult because then there's potential for it to have gotten further and further from the room. That broadens, and then we have to search further and further. And every once in a while, we actually can't find the seed, and then we have to report that to the city. But really good record keeping is how we prevent that. Just really keeping track of how many seeds you brought to the OR, how many seeds are leaving the OR, real-time inventory as they're being implanted. A typical prostate implant can be anywhere from 40 to 80, 90 seeds or more. So when you're dealing with so many small sources, it's easy for them to go missing. We get seeds from the vendor that are calibrated. There's a certified strength on them. So you could trust the vendor. However, we always, the brachytherapy group does do calibration on the sources prior to implantation. It's just seen as a prudent measure. Another set of eyes, another set of instruments on the source, just to make sure that we weren't accidentally sent a source that is maybe 10 times stronger or 100 times stronger, which could have a significant clinical effect once they're implanted. A permanent implant is not going to be easy to get out once it's implanted. So it makes sense for us, or for us as a whole of MSK, to measure the strength of the seed before they are put into a patient. It's a whole process to make sure these sources can actually go in a patient. They need to be sterilized prior to the procedure. The shielding needs to be sterilized prior to the procedure. Any sort of applicators need to be sterilized. It's going to be going in an OR. It's going to be used in a surgical procedure. So that's just par for the course. Anytime you're handling these seeds, handling these sources, you need to make sure that you're using long-handled tools. You don't want to just pick up a source in your hand. You have to manipulate them in a way to minimize potential contamination. One of our old cases was a P32 plaque, which was essentially a little piece of thin plastic that was impregnated with phosphorus 32, which is a strong beta emitter. They used to cut these sources to shape them to the tumors, but we found that as these sources are cut, the area that's cut sheds a lot of contamination, and that's not supposed to happen with a sealed source. And we actually had to step in and say, listen, we know these sources are leaking when they're cut, which means that they are leaking inside of the patient, which means they're leaving behind radioactive phosphorus. That's just not acceptable to us. So we had to start forbidding the cutting in the OR of these sources. So what they do is they would instead order a number of different size sources, and then once the surgeon gets into the actual surgery and sees the size of the tumor, has a better idea of the geometry of it, they can then dictate which source they want to use to best cover that tumor, and that avoided that issue of contamination in the OR, which was a serious issue. I was getting ahead of myself. So the leak tests are important for these sealed sources because you want to be able to ID that if they are leaking, they may not leak when they're produced, but if you have a source that's got, a 30-year half-life, that may be in service for 10, 15 years before it's taken out. And at that point, it may start to leak. The radiation itself may start to break down the material. It's just, it's use, it's repeated sterilization. There's lots of wear and tear on these sources. So the regulations say that you should leak test them every 6 months. unless they are in storage, at which point you leak test them prior to the use. Some sealed sources have a device registry, which may say something else. You may say need to be retested every 3 months, but as long as nothing can exceed that 6 months. So there's nothing that can say, oh, you only need to leak test once a year, because the regulations trump any sort of device registry. So you also have surveys. There's certain situations where it's very important to survey after the source is supposedly withdrawn from the patient. You want to make sure that that source is actually out, especially if you are dealing with something like a 10 curie HDR source. It's very important to know that that source has been withdrawn from the patient and is back in the shielded container. So that's what we get to here, is that immediately after the implant is removed, you have to take it out. After a temporary implant, you have to make sure that it came out, whether it's a low dose source or a high dose rate source. That's just a simple way to make sure that there's no potential hazard for anyone in the room, and especially the patient. These sources are moving all around the institute. They get shipped to us, they get shipped back. So there's a lot, again, like I've mentioned, logistics that make sure that these sources are safe in transit. It's helpful that they're sealed sources, but some of them can be very high dose rates, like an HDR source, like the name would hint, that they can have very high dose rates. So these sources coming and going from our institute need to be in very heavily shielded containers. It's a pretty extensive shipping process to get them out of our institute. Thankfully, the vendor does most of that. That needs to be kept in mind as that source travels. There is a lot of licensing that is involved in having these sources. They're very specifically listed on our license, not just the source, but the physicists that will be responsible for calibrating and bringing the sources to the OR, and the radiation oncologists who will actually be performing the implants. So we have these specifically listed on our license. It's important that they're up to date, because if you ever had a situation where there was a medical error in an OR and the MD performing the procedure is not listed on your license, you would be in a lot of trouble and from a regulation standpoint, because that means the city would not have vetted the physician for their training and experience. They may not be boarded. There's a lot of reasons why they want to have a very extensive vetting process for some of these procedures, because some of them are very high stakes. So for patient release, we do release patients with sources inside of them, which means that they are radioactive. Generally, the patients we release are less radioactive than some of the loose radiopharmaceuticals we use, some of the nuclear medicine procedures. But there are still instances where there may be dose rates above which we need to give precautions. So we're allowed to release a patient to the public, release them out of the hospital there's a number of stipulations you have to meet. So this is coming directly from the NRC. They say that there is, above a certain activity of treatment, you may have to keep the patient in-house, or if that activity is exceeded, then you can defer to the dose rate coming off the patient. And dose rate will always be less limiting, because the dose rates that they list for the regulation are taken as unshielded sources. So the activity correlates to the dose rate through something called the gamma constant. Again, that's something we'll cover when we talk about shielding. But that pretty much tells you that at a certain activity, for a certain isotope, you can expect a certain amount of radiation at a certain distance. That's what a gamma constant does. So activity is related to dose rate very directly for a certain isotope and for certain exposure at a certain distance. So a lot of times we'll use the dose rate, because if you think about it, this activity, where is it? It's inside of a patient. That patient is made up of materials, predominantly water, that will serve to shield that radiation. So it would be less of a dose rate than if it was the same amount of activity just sitting on a benchtop somewhere. The actual patient itself can shield that activity, sometimes up to a factor of 50% or more. So you'll always, if you go by dose rate, you'll always be better off in terms of who you can release. And then beyond that, you can actually go one step further, and you can do your own calculations saying that if we release this patient, no member of the public is at risk of being exposed to more than 500 milligram. And that 500 milligram is a little different than that blanket 100 milligram member of the public dose that we talked about, because that 500 milligram generally corresponds to family members. The highest exposed person from a patient leaving our hospital will be a family member that's taking care of the patient. So that's seen as a situation where a higher limit is acceptable, because it's in the best interest of the patient, and usually the family member too, to be able to have that family member home, be able to be treated at home, or just home with family as opposed to stuck in a hospital. So that's where that a little extra level of dose is allowed. So I mentioned that there have common accidents. Some procedures are more prone to accidents than others. Something as minor as a lost seed, a single brachytherapy seed is unlikely to harm somebody, but a lost HDR source is very likely to harm somebody. So you have to gauge the sort of level of the accident, potential accident, when you're thinking of ways to prevent accidents. One of the big ones you see here, this is an HDR source that was incorrectly placed. That's a big one. HDR sources, they are tied to a catheter line that runs through a catheter. So you need to have a very well-known and well-established length of catheter to actually send the source out to the right spot. So sometimes if you use the wrong length catheter, the source will go out to where it thinks is where it's supposed to go, but it can be either too short or too long. So if you're going to a specific spot and it actually ends up just being superficial to the skin, and you will get a huge skin dose from that situation, and you can get something like I won't go back to the picture, but something like a terrible skin burn like that. And unfortunately, we have had situations like that in our hospital where just the source is not where it is expected to be, whether it is a fault of the machine or a faulty catheter length. But there's also the situation where the source, after the treatment time, whether it's a couple seconds or a minute or whatever, fails to return to the actual shielded afterloader. And that's a big problem because the 10 curie source is putting out a lot of radiation very quickly. So this is something that if you are the physicist or the physician administering an HDR treatment, you have to be prepared to, if the source does not retract, quickly enter the room, manually pull the source out of the patient. There's an actual manual crank that will pull the source back into the afterloader. And we have what we call a doghouse. So inside this heavily shielded room, we actually have a little more heavily shielded closet that, in the worst case scenario where the automatic retraction fails, the manual retraction fails, we are able to just grab the source and just toss it into this small shielded closet in order to, it's not a perfect shielding, but it will significantly reduce the dose rates to get the patient out of there and to take stock of the situation and how to handle it. But yeah, these are much higher stakes than a lot of the low dose rate stuff, because you can get very harmful doses very quickly. There's a lot of quality assurance information in that TG40. I'd mentioned this last time we met. The TG40 covers pretty much all radiation oncology procedures. And then that TG142 is an update exclusively for external beam for linear accelerators, just because of their, the advances over. I think TG40 is from the late 80s or early 90s. So you can imagine that there was a necessary update for the actual Linacs, because they have advanced much more than brachytherapy sources. So I'd mentioned, we've had a couple instances of issues in our hospital, the biggest being just, dose to skin, dose to areas that were not the tumor. That is a big deal. That can cause the patient a lot of harm, a lot of pain. So we hate to see that. But there is one HDR event that really stands out above all the others. And there was an instance where an elderly patient, had an HDR source actually break off inside of them. And if that's not bad enough, it was not noticed by the hospital staff. So this patient, the treatment was finished. It was thought to be finished. This patient, left the hospital. They were in a nursing home. So they went back to their nursing home with this 10 curie source still inside of them. their health started to plummet very rapidly because they're being internally exposed with huge amounts of radiation. But by the time they realized that it was because of this HDR source, she had exposed a number of patients in the facility that she was living at, a number of staff. There were large doses to a lot of people, all because there was not a simple survey at the end of the procedure making sure that source was retracted. So we have processes, policy in place that says that, you know, the first person to enter after an HDR procedure should be holding a dose rate meter. We actually have fixed area meters on the walls with displays that are outside the vault. So even if you don't have a handheld, there's a permanent meter there that will let you know that the source has been retracted. And this is all to avoid some sort of disaster scenario like that. And it should work. You can't be 100% confident in anything, but that's a pretty good way to know that the source will not leave that vault. That's it for brachytherapy. We'll talk about that next Wednesday. Thanks.